In this lesson, we'll discuss urologic tumors and other urologic diseases. There are two parts in this lesson. The first part is urologic tumors, including renal cancer, bladder cancer, and prostatic cancer. The second part is other urologic disease, including cryptorchidism, phimosis, and redundant prepuce, prostatitis, and hydrocele. The first part is urologic tumors. Renal cell carcinoma originates from the renal parenchyma and is the most common renal malignancy. It accounts for 2 to 3% of adult malignancies. Most renal cell carcinoma are round to ovoid and circumscribed by a pseudocapsule of compressed parenchyma and fibrous tissue rather than a true histological capsule. Unlike upper tract transitional cell carcinomas, most renal cell carcinomas are not grossly infiltrative, with the notable exception of collecting duct renal cell carcinoma and some sarcomatoid variant. All renal cell carcinomas are adenocarcinoma, derived from renal tubular epithelial cells. There are several histological subtypes. Clear cell renal carcinoma account for 60 to 85%. Papillary renal cell carcinoma occupies about 7 to 14%. Chromophobe renal cell carcinoma is about 4 to 10%. Collecting duct carcinoma is about 1 to 2%. Undifferentiated carcinoma is less than 1%. Because of the sequestered location of the kidney within the retroperitoneum, many renal masses remain asymptomatic and non-palpable until they are advanced. With the more pervasive use of non-invasive imaging for the evaluation of a variety of non-spec symptoms, more than 50% of renal cell carcinoma are now detected incidentally. The classic triad of flank pain, gross hematuria, and palpable abdominal mass is now rarely found. Paraneoplastic syndromes are found in 20% of patients with renal cell carcinoma, including fever, hypertension, hypercalcemia, hyperglycemia, and polycythemia, etc. Pathological fracture, cough, hematesis, pain can be found in patients with metastasis. Diagnosis of renal cell carcinoma requires imaging evaluation. The sonography, excretory urography, CT, and MRI are commonly used. Ultrasound is used to distinguish cystic from solid renal mass. It can also distinguish renal cell carcinoma from renal angiomyolipoma and detect renal tumor larger than 1 centimeter in diameter. Excretory urography can show the renal enlarged contour and deformation of renal pelvis and calyces. CT has the important value in the diagnosis of renal cell carcinoma and can distinguish renal cell carcinoma from renal angiomyolipoma and renal cyst. MRI is most effective in demonstrating the extent of renal cell carcinoma invasion. Radical nephrectomy is the most important treatment for localized renal cell carcinoma, has been the gold standard curative operation. Partial nephrectomy entails complete local resection of the renal tumor while leaving the largest possible amount of the normal functioning parenchyma in the involved kidney, has been widely used for the management of T1 renal tumors, even in the presence of a normal contralateral kidney. Renal cell carcinoma is not sensitive to radiotherapy and chemotherapy. Targeted molecular agents and immunotherapy has been used for advanced and metastatic renal cell carcinoma. Bladder cancer is the most common tumor in the urinary system, most of which originates from epithelial tissues. There are several histological subtypes. Transitional cell carcinoma is the most common pathological type of bladder cancer, accounting for more than 90%. Squamous cell carcinoma is uncommon, accounting for 3 to 7%. Adenocarcinoma is rare, only less than 2%. This is the T&M staging system for bladder cancer. TA and the CIS disease have no invasion of the basement membrane. T1 tumor invades subepithelial connective tissue. T2 tumor invades muscularis proprius. T3 tumor invades perivascular tissue. And T4 tumor invades adjacent organs, such as prostate stroma, uterus, and vagina. Hematuria is the most common and earliest symptom of bladder cancer. The presence of irritating voiding systems, such as frequency, urgency, and pain, may be the manifestations of advanced bladder cancer and CIS. Anemia and pain can be found in patients with metastasis. The evaluation of suspected bladder mass consists of urine cytology, imaging examination, and visual inspection of the urothelium. Urinalysis and urine cytology are used as preliminary screening for hematuria patients. Ultrasound can detect tumor larger than 0.5 centimeter in bladder and show the depths of tumor invasion. Excretory urography has been the imaging modality for the urinary tract with the improvement of technology. CT and MRI urography has been widely used. CT and MRI scan can help to confirm the clinical stage of bladder cancer and demonstrate hydronephrosis. TA, T1, and localized T2 tumors can be managed with bladder preservative therapy, such as transurethral resection, partial cystectomy, and intravesical chemotherapy or BCG instillation. Radical cystectomy and urinary diversion should be used for large, multifocal, recurrent, or high-grade T2, T3 lesions, squamous cell carcinoma, and adenocarcinoma. For T4 tumors, radiotherapy and chemotherapy might be helpful. Low-grade CIS can be managed with intravesical therapy. Radical cystectomy should be considered for high-grade CIS. CIS with papillary tumor, muscle invasion, and BCG failure. Prostate cancer has become the most common tumor in men and the second greatest cause of cancer mortality in the United States. In China, the incidence of prostate cancer is also gradually increasing. Adenocarcinoma is the most common pathological type of prostate cancer, accounting for 98%. Other subtypes, such as ductal carcinoma, small cell carcinoma, and transitional cell carcinoma, occupy only about 2% of prostate cancer. Gleason system has emerged as the standard grading system for prostate cancer. The Gleason system is based on the glandular pattern of the tumor, as identified at relatively low magnification. Architectural patterns are identified and assigned a grade from 1 to 5, with 1 being the most differentiated and 5 being undifferentiated. The two most common patterns are added together to provide Gleason score with the grade of the most predominant tumor listed first. Gleason score 2 to 4 is well differentiated. 5 to 7 is moderate differentiated, and 8 to 10 is undifferentiated. This disease has few dramatic primary signs and symptoms. It may be associated with hematuria, urinary obstructive symptoms, including frequency, urgency, dysuria, urinary retention, and urinary incontinence. Bone pain and anemia can be found in patients with metastasis. Digital rectal examination has important value for the diagnosis and staging of prostate cancer. Prostate-specific antigen is the classic and useful marker for prostate cancer, and the normal value is less than 4 nanogram per milliliter. Transrectal ultrasound is sensitive, but not specific for the detection of prostate cancer, and can be useful in needle biopsy. Transrectal ultrasound-directed prostate needle biopsy remains the gold standard for the diagnosis of prostate cancer. Bone scintigraphy is most sensitive for the detection of skeletal metastasis. MRI can evaluate the local extent of disease and the possibility of node involvement. Radical prostatectomy can be used for tumors confined to prostate capsule and even some selected T3 and T4 tumors. External beam radiation therapy is also an option for localized prostate cancer and treatment choice for T3 disease. Androgen deprivation therapy, anti-androgen, and chemotherapy can be used for advanced disease. The androgen deprivation therapy consists of bilateral orchiectomy, LH agonists, and antagonists. The second part is other urological disease. Cryptorchidism is referred to the failure of one or both testes to permanently descend, otherwise referred to as undescended testes. It's a potential manifestation of testicular dysgenesis syndrome at birth. Watchful waiting can be used for children younger than 1 year old. For those 1 to 2 years old, LHRH or HCG should be given. Orchidopexy should be performed for those older than 2 years. Phimosis is the abnormal constriction of the foreskin that prevents it from being drawn back to uncover the glans penis. Redundant prepuce is referred to the foreskin completely covering the penis and urethra, but it can still be drawn back. Circumcision should be considered for phimosis. Classification of the prostatitis is based on the presence of prostatic inflammation and bacterial infection. Acute bacterial prostatitis is usually caused by the retrograde bacterial infection and hematogenous infection. Chronic bacterial prostatitis is also caused by the retrograde bacterial infection. Non-bacterial prostatitis might be caused by the infection of chlamydia, trachomatis, mycoplasma, trichomonas, fungus, and virus. Frequency, urgency, dysuria, and fever can be present in patients with acute bacterial prostatitis, usually requiring hospitalization and broad-spectrum parenteral antibiotics. Frequency, urgency, dysuria, and pelvic pain can be found in patients with chronic bacterial prostatitis, usually requiring auto antibiotics, such as fluoroquinolone for 4 to 6 weeks or even longer. The manifestation of chronic non-bacterial prostatitis is similar to chronic bacterial prostatitis. Antimicrobials may be helpful. Hydrocele denotes a pathological accumulation of serous fluid in processus vaginalis. There are 4 subtypes, including testicular hydrocele, funicular hydrocele, testicular and funicell hydrocele, and communicating hydrocele. Usually no treatment is required for infants, and surgery is required for adults. That's all. Thank you for your attention.